All right, this is our makeup for QIM Education. We're going to get started here. We're going to go over our QIM certification and testing, our QIM daily charting, and our admission and discharge forms. So why is QIM important? QIM is important to rehab because this is how we measure our patients' outcomes and their functional improvements, mostly their ability to perform ADL tasks, and these are reported to the Centers for Medicare and Medicaid. So these are forms we are required to complete and fill out for each of our patients. How do you become QIM certified to do the QIM charting? You are going to be taking a test this September. It is open as we speak. This test is open book. It is open resource. It allows for retests on low score areas. So any section that you do not get an 80% or above on, you'll be able to retake with, again, open book and open resource. And I have my phone number in our resource book. That is where the rehab nurses sit. If you guys have any questions while you're taking the test, feel free to text me a picture or let me know what you need help on and I can help you. I'm also part of your open resources. So we're going to go through all of our testing and our charting here, and I'll speak a little bit more about the testing once we get to it. But we'll start with the charting. So for charting, we have our QIM daily report, our nursing admission and discharge, and our QIM weekly team conference. All of these forms can be found under the ad hoc button in Cerner, and we're going to go over all of these forms here. So this is our QIM daily report to start. This is what you're going to be doing each shift that you work in rehab, day and night. We have a couple different sections here. We're going to be going over these upper and lower sections later, but to start, we're going to be going through this big section in the middle. This is what you're mostly going to be tested on for your QIM certification, and these are the questions you'll get asked the most in your testing, so we're going to go over these to start. When you chart, you are only ever going to chart in these performance boxes. You're never going to chart in the discharge goal. That's for our therapists to set. And you can see we have eating, toileting, hygiene, dressing, getting out of bed, walking, transfers. We're going to go over all of these here. And so if you saw your patient eat, you're going to click on this box right here to chart on it. And when you click on those boxes, it's going to open up this little window. It gives you the option on how you're going to score your patient's performance on this ADL task. So oral hygiene, did they do it independently with setup or cleanup assistance, supervision or touching assistance, partial, moderate, substantial or maximal, or dependent. There are options over here if they did not complete the task, if they refused it, if it was not applicable, or if it was not attempted due to medical conditions or safety concerns. For the test, you'll need to understand and know these options. In real-world rehab charting, we are charting by exception. So if for some reason we did not eat because we're NPO, we're just not going to chart that we did it. If we didn't do oral hygiene because we refused, of course we can always hit refuse. But these options are more for our testing than they are for our charting. And so I encourage you guys just to do a kind of a chart by exception rule. If for whatever reason, they did not get a shower because they were showering with OT and you didn't see it happen, then you're not going to chart on shower. So for our coding options here, independent's pretty self-explanatory. They did it by themselves with no assistance from a helper. Setup or cleanup assistance, the helper sets up or cleans up the patient while the patient completes the activity. The helper assists only prior to or following the activity. Supervision or touching assistance, this is kind of that reminder, verbal cues, reminders for touching and steadying assistance. This is not helping lift. This is not helping move. This is just kind of being there in case they do need help. Partial or moderate assistance, you are helping lift, you are giving effort for the patient, but you are doing less than half of the effort required to complete the task. So you might help lift an arm or a leg, or you might give a little boost when you stand up. And then substantial maximal assistance, the helper does more than half the effort. You are performing more than 50% of the effort needed to complete the activity. And then dependent, the helpers do all of the work. And so for our charting, this is always going to be 2 or more people. 2 or more people is usually going to be a dependent coding for our patients. And then, like we said, there were some other options there that we can use. These, again, are mostly for our testing, not so much for our charting. Patient refused, you can always use that if they refused it so that we can accurately reflect why something didn't happen. Otherwise, these not applicable, not attempted, are more for our testing situation. If they did not do it because of a current illness or injury, did we not do it because of environmental limitations like lack of equipment, weather constraints, or did we not attempt due to medical conditions or safety concerns? And I'll try and give you guys some examples of these as we move through our presentation. So we're going to start with eating. Eating is the patient's ability to use suitable utensils to bring food or liquid to the mouth and swallow once the meal is placed before the patient. So if you put the tray in front of the patient and you walk away, that is independent. Putting the tray in front of the patient does not count as setup or cleanup assistance. Setup or cleanup assistance starts when we start opening food lids, cutting food, putting straws into things. Supervision or standby, that can be our one-to-one or repeated cues to swallow. Partial or moderate, substantial or maximal, or dependent. So if we have a new tube feed or new TPN, we are going to code this for our testing as not attempted due to medical condition or safety concern. We're not going to be eating if we need to be NPO and we're not able to take food in by mouth. If this is old TPN, old tube feed, we are not applicable, not attempted, because the patient did not perform this activity prior to the current illness. They were not eating before they came to us. We are not going to start doing it now. Obviously, this can change with speech therapy in real life, but some of these rules in this presentation are more to help you guys pass the test for certification. I understand that the real world has some more nuance, especially with patients' ability to perform tasks. So these are more for your test, but completely applicable if you need to in the real world. Scoring for eating does not change based on the type of diet. They can be a pureed, honey thick liquid diet. As long as they are able to eat, we're scoring them on how they eat, not what they're eating. So we're going to be doing a practice question for each of our sections here. All of these questions I pulled out of the resource book that you guys will use for your testing, your open book test. So all of these are reflective of what you might see in your testing. The patient has upper extremity weakness and fine motor impairments. The occupational therapist places an adaptive device onto the patient's hand that supports the eating utensil within their hand. At the start of each meal, the patient can bring food and liquids to their mouth. The patient then tires, and a certified nursing assistant feeds the patient more than half the meal. I encourage you guys to give your best guess for this. We're going to go to the answer after a couple of seconds for each of these, so you guys can have time to pause and guess. And our answer is substantial or maximal. The helper provides more than half the effort for the patient to complete the activity of eating each meal. Oral hygiene. Oral hygiene is the ability to use suitable items to clean teeth or dentures. Oral hygiene for dentures includes insertion, removal, rinsing, or soaking. So even if they don't have teeth, we can still code them for oral hygiene. Our question here, the patient is edentulous or toothless, and their dentures no longer fit their gums. The patient begins to brush their upper gums after the helper applies toothpaste onto the toothbrush. The patient brushes their upper gums but cannot finish due to fatigue. The helper completes the activity of oral hygiene by brushing the patient's back upper gums and lower gums. The answer is substantial or maximal. The patient begins the activity and the helper completes the activity by performing more than half the effort. Toileting hygiene. So this is not just perineal cleansing. Toileting hygiene, for the sake of our charting, also includes managing clothing. So this is pulling their pants down, cleaning, and then pulling their pants back up. If the patient has an ostomy, hygiene only involves wiping and emptying, not management of equipment like replacing the bag. But this would still include management of clothing, so pulling down pants or pulling up shirt, emptying their ostomy, cleaning and closing. The question states that the patient has urinary urgency. As soon as the patient gets in the bathroom, they ask the certified nursing assistant to lift the patient's gown and pull down the patient's underwear due to the patient's balance problems. After voiding, the patient wipes themselves, pulls their underwear back up, and adjusts their gown. The answer is partial or moderate assistance. The helper provides more than touching assistance, and the patient performs more than half the effort. The helper does less than half the effort. Toileting transfer. Toileting transfer involves a patient's ability to get on and off a toilet or commode. This does not include transferring on or off a bedpan, but raised toilet seats are okay. And for context here, toileting hygiene can happen anywhere. So a toileting hygiene can be coded on a bedpan if a patient's able to pull their pants up and down, use the bedpan and clean themselves up. But toilet transfer is not okay for a bedpan. They have to be going to the actual toilet or commode. A certified nursing assistant moves the wheelchair footrests up so that the patient can transfer from the wheelchair onto the toilet by themselves safely. The certified nursing assistant is not present during the transfer because supervision is not required. Once the patient completes the transfer from the toilet back to the wheelchair, they flip the footrest back down themselves. The answer is setup or cleanup assistance. The helper provides setup assistance, moving the footrests out of the way, before the patient can transfer safely onto the toilet by themselves. Rolling left to right. Rolling left to right is coded on the patient's preferred sleeping surface and to both sides. If the patient needs more help on one side than the other, code for the overall amount of assistance required. It's a little bit silly. It says preferred sleeping surface on here, but some of the questions will state that patients are allowed to sleep on any surface, so our recliner chairs do count for them if they need it to be. Rolling left and right, the patient has a history of skin breakdown. A nurse instructs the patient to turn onto their right side, providing step-by-step instructions to use the bed rail, bend their left leg, and then roll onto their right side. The patient attempts to roll with the use of a bed rail, but indicates they cannot do the task. The nurse then rolls the patient onto their right side. Next, the patient is instructed to return to lying on their back, which they successfully complete. The patient then requires physical assistance from the nurse to roll onto their left side and to return to lying on their back to complete the activity. This is going to be substantial or maximal assistance. The nurse provides more than half the effort needed for the patient to complete the activity of rolling left to right. During our classes, this one really tricked people up. So if we go back through it, some of these questions are going to give you information that are absolutely not pertinent to how you're going to score them. So the patient having a history of skin breakdown doesn't matter. But if we look at the meat of it here, the patient attempts to roll with the use of the bed rail, but they cannot do it. So the nurse rolls them onto their right side. So we've already helped them go one way. The patient is instructed to return to laying on their back, which they successfully complete. The patient then requires physical assistance from the nurse to roll onto their left side and to return to lying on their back. So I'd say the patient only does about 20% of the actual effort here. The only thing they were able to do by themselves was to roll back onto their back from their right side. And that's why it's substantial or maximal. But they're still doing some effort, so not dependent. Sitting to lying and lying to sitting. The ability to move from a sitting on the edge of a bed to lying flat on the bed, and the ability to move from lying on a bed to sitting on the edge of the bed. Our question here, the patient requires assistance from a nurse to transfer from sitting at the edge of the bed to lying flat on the bed. The helper lifts and positions the patient's right leg. The patient uses their arms to position their upper body and lowers themselves to lying position flat on their back. The answer is partial or moderate assistance. The helper lifts the patient's right leg and helps the patient position it as they move from a seated to lying position. The helper performs less than half of the effort. Chair to bed and bed to chair transfers. Chair to bed to chair transfers start with the patient sitting on the edge of a sleeping surface and ends when they sit in their wheelchair or chair. The patient is able to use a recliner as their, quote, sleeping surface. This does not require taking several steps between chair and bed. So the chair doesn't have to be far away from the bed. They don't have to walk there. So at most, or at minimum, we're doing like a stand pivot, squat pivot, or slide board transfer to be able to code this. And all of these scenarios I have down here, all of these examples are just a more condensed version of what you're going to find in your book. Your book is going to have far more resources for you. So I encourage you guys to use your book when you're testing, but a copy of this is available in the book at the very beginning. All of these slides are available there. The patient had a stroke and is not currently able to walk. They use a wheelchair for mobility. When the patient gets out of bed, the certified nursing assistant moves the wheelchair into the correct position and locks the brakes so that the patient can transfer into the wheelchair safely. The patient had been observed several other times to determine any safety concerns, and it was documented that they transfer safely without the need for supervision. The patient transfers into the wheelchair by themselves, with no helper, after the certified nursing assistant leaves the room. The answer is setup or cleanup assistance. They are not able to walk, which is not required for this task, so they transfer from their bed to a wheelchair when getting out of bed. The helper provides setup assistance only. All right, sit to stand, self-explanatory. The patient has multiple healing fractures and multiple sclerosis, requiring the assistance of 2 certified nursing assistants to assist the patient to stand up from sitting in a chair. This is dependent. Like we said at the beginning, if you're going to have 2 people helping for our test, it is going to be dependent. Obviously, in real-world nursing, you can have a more nuanced scenario where it takes one person to transfer and then another person maybe to help pull down undergarments and briefs if we are transferring to the toilet and things like that. It only took one person to transfer, but our second person is more of an aid for clothing management and things like that. So you guys use your best judgment when you're charting in real life, but for our testing scenarios, 2 is going to be dependent. Car transfers. So this is a big one that we end up missing on our charting for our QIMs when patients arrive to our facility. A lot of our patients are admitted from other facilities, usually St. Pat's or Logan Health. And so if they aren't coming from med-surg or ortho, if they're coming from outside, they're usually coming in some type of vehicle. So if we see them transfer, we need to code this on their first day so that we have a view of how they were able to transfer when they first got here versus when they go home. So I encourage you guys to chart as much as you can on the first day or the first couple days of a patient's admission so that we have a good baseline for how they progress, and especially with car transfers. And this one's pretty specific. The ability, car transfer is the ability to transfer into or out of a vehicle on the passenger side. Coding does not include the ability to open or close the door or fasten the seatbelt. Indoor car simulators can be used, and the use of a mechanical wheelchair onto a ramp does not count. So our occupational therapists are going to be doing these indoor car simulators. That's not going to be a nursing thing. And if the patient is able to use a mechanical wheelchair, it does not count. They have to be able to transfer into a seat in a car. So the patient uses a wheelchair and ambulates for only short distances. They require lifting assistance from a physical therapist to get from a seated position in the wheelchair to a standing position. The therapist provides trunk support when the patient takes several steps to turn and transfer into the car. The patient lowers themselves into the car seat with steadying assistance from the therapist. The patient lifts their legs into the car with support from the therapist. The answer is substantial or maximal. This one also tricked people up in the class. The rationale is that although the patient also contributes effort to complete the activity, the helper contributes more than half the effort needed to transfer the patient into the car by providing lifting assistance and trunk support. So if we go back again, every step of the way, the therapist is providing support to stand, to steady, to lift, to place. And so we could argue here that they are doing more than half the effort. Lower body dressing. The ability to dress and undress below the waist. A hospital gown is not appropriate to code for this. We need pants, shorts, something like that. This does not include footwear or AFOs, but it does include a prosthesis or compressive sock sleeve necessary for ADLs. Our AFOs and footwears are going to be included in our footwear dressing. This is lower body dressing, and so prosthesis counts because it's usually a prosthesis already has the shoe on it, and so we're applying this to our BKAs, our AKAs, and that's more of a leg than it is a foot. So the patient is required to follow hip precautions as a result of recent hip surgery. The occupational therapist in the acute care hospital instructed the patient in the use of adaptive equipment to facilitate lower extremity dressing. The patient requires a helper to retrieve the patient's clothing from the closet. The patient uses their adaptive equipment to assist in threading their legs into the pants. Because of a balance issue, the patient needs the helper to steady the patient when standing to manage pulling on or pulling down the patient's pants or undergarments. The patient also needs some assistance to put on and take off their AFO, socks, and shoes. So this is only supervision or touching assistance. This one was also a tricky one. It gives you more information than you need to answer the question. The helper steadies the patient when the patient is standing and performing the activity of lower body dressing, which is supervision or touching assistance. Putting on and taking off socks and shoes is not considered when coding lower body dressing, nor is putting on and taking off orthotics associated with the foot, for example, an AFO. These are considered when putting on or taking off footwear. So like I said, some of these questions are going to give you more information than you need. It's talking about footwear stuff when we're coding for lower body dressing. It's saying that they have hip precautions and they are allowed to use adaptive equipment to complete their activities. It's dependent on how much help they need with those equipments, those adaptive equipments. Upper body dressing. The ability to dress and undress above the waist. This should be something other than a hospital gown again, and it includes TLSO braces or bras if applicable. Also abdominal binders if needed. That is going to be an upper body dressing because we are above the waist. Upper body dressing. The patient wears a bra and sweatshirt most days while in the rehab program. The patient requires assistance from a CNA to initiate the threading of their arm into their bra. The patient completes the placement of their bra over their chest. The helper hooks the bra clasps, and the patient pulls the sweatshirt over their arms, head, and trunk. When undressing, the patient removes the sweatshirt with the helper assisting them with one sleeve. The patient slides the bra off once it has been unclasped by the helper. For this one, it's going to be partial or moderate assistance. The helper provides assistance with threading the patient's arms into their bra, hooking and unhooking the clasps, and assistance with removing one sleeve of the sweatshirt, but the patient performs more than half of the effort. Footwear. This does include our socks and AFOs, so the ability to put on socks, AFOs, and shoes, or other footwear that is appropriate for safe mobility. Remember, this does not include our prosthesis, but grippy socks are okay for coding. So if all we have is a grippy sock for our patient, we can code them with that too. The patient is undergoing rehab for right side upper and lower body weakness following a stroke. The patient has made significant progress towards independence and will be discharged to home tomorrow. The patient wears an AFO that they put on their foot and ankle after they put their sock on, but before they put on their shoes. The patient always places their AFO, socks, and shoes within easy reach of the bed. While sitting on the bed, the patient needs to bend over to put on and take off their AFO, socks, and shoes, and the patient occasionally loses sitting balance, requiring staff to place their hands on the patient to maintain the patient's balance while performing this task. This is going to be supervision or touching assistance. The patient puts on and takes off their AFO, socks, and shoes by themselves. However, because of occasional loss of balance, they need a helper to provide touching assistance when the patient is bending over. Some people were answering setup or cleanup assistance for this, but you got to read carefully here. It says that they always place their AFO, socks, and shoes within easy reach of the bed, so they don't need setup or cleanup assistance. They've already done it themselves. They need steadying assistance, which is going to be that supervision or touching assistance. Shower or bathing. This is usually done by our OTs, but you guys are able to code it and you will be tested on it in case you do any showering. Shower and bathing self include the ability to wash, rinse, and dry face, upper lower body, perineal area, and feet. This does not include washing, rinsing, and drying of the patient's back or hair. If you are showering them, please wash their back and hair, but for the sake of the test that you're going to take, it does not require them to do so. This does not include transferring in or out of the shower. Assessment of a shower bathe self can take place in any location, including a shower, bathtub, sink, or bed for a full body sponge bath. Bathing can be assessed with the patient seated on a tub bench. The patient has a severe and progressive neurological condition that has affected their endurance as well as their fine and gross motor skills. The patient is transferred to the shower bench with partial moderate assistance. When showering, the patient uses a wash mitt that was provided by the acute care facility prior to their admission to the post-acute care facility. The patient showers while sitting on a shower bench and washes their arms and chest using a wash mitt. A certified nursing assistant must help them wash the remaining parts of the patient's body as a result of the patient's fatigue to complete the activity. The patient uses a handheld shower head to rinse themselves, but tires halfway through the task. The CNA dries the patient's entire body. This one's going to be substantial or maximal. We are doing far more than half of the task. We are doing all of the drying, we're doing some of the washing, and again, the transfer onto the shower bench is not considered in coding this activity. So they're trying to trick you with some of the information they give you for these. So we're going to go over bowel continence and bladder continence for the sake of your testing. We are still trying to figure out a good way to chart this specifically for our nurses in rehab, because both bowel and bladder continence are recorded for the first 3 days and then charted on the 3rd day. We do not have a consistency of staff where we can track this information in a realistic way for you guys. They might have 3 different nurses the first 3 days, and trying to track this and chart this is just not feasible right now. We are working on a system, and when that system comes out, I will email you all to let you know what we've decided on. Right now, we're working with changing the I's and O forms. So when you go to put in a urine count or a stool count, I'm trying to get them to add one that says incontinent stool and continent stool, and then an incontinent urine and continent urine. So that way you guys would just be able to chart them that way. And then Kelsey Wong, who is our Earth Pi person, would be able to go through our charts, tally those all up, and then chart this for us. But like I said, we're working on that system for the real world, but these slides are good for your testing. You will be tested on it. And so there are some rules here about bowel continence. We have just a few options here. Occasionally incontinent applies if the patient was incontinent only once during the 3-day period. Frequently incontinent applies if the patient was incontinent at least twice, but also had at least one continent bowel movement. And then a bowel program is considered continent if stool is evacuated in an appropriate amount of time. I would say this is probably 30 minutes or less. If we've done our bowel program from the start of our bowel program to the completion, we're looking for around 30 minutes or less for a successful bowel program. If their bowel movement happens 2 hours later, that is going to be considered an incontinent stool. And then bedpan, toilet, or bedside commode use does not affect continence. Okay, bladder continence is same thing, recorded for the first 3 days, charted on the 3rd day. If a patient sometimes needs straight caths to drain the bladder, then we are going to code them based on their continence between straight caths. If the patient always needs straight caths, code them to be continent. Only chart not applicable if the Foley is in place for the entire 3-day period. And patients are able to use a condom cath or Purewick, but it should be noted whether or not this is for incontinence or if it is used for patient comfort on a continent patient. And then there is an option for stress incontinence, and there's just a little thing there for you to remind you what our options for stress incontinence includes. All right, so we are back to our form here. We've gone through all of these middle sections, all of our ADL tasks. If you see down here, we have some other options that we didn't go through. These are more for our physical therapists, walking 10 feet on uneven surfaces, going up 1 step, 4 steps, 12 steps. This does not mean taking 12 steps. This means going upstairs. Picking up object. This is also not just can they pick up their remote from their table. This is, are they standing and can they pick up a object off the floor? We are not trying to chart these. We are not trying to code these. We are not testing patients on these. But our therapists have the same form here, and so they're available. So a reminder, we do not chart discharge goals. We are only charting in these white boxes. And then again, we have that bladder continence, bowel continence section down here. This other little box on the right, swallowing and nutritional status, they have 3 options. People can either be eating regular food, a modified consistency food, or eating with supervision, or they need tube feeding. So only 3 options for that, and that you guys are able to chart on. And then we're going to go over this top section here, expression and understanding. So this is how well do they understand you and how well are they able to express themselves. So a lot of our patients are going to be stroke patients, and very specifically I want to bring attention to this first option here for expressions of ideas and wants. So how well are they able to express themselves? It says expresses complex messages without difficulty and with speech that is clear and easy to understand. Unfortunately, a lot of our stroke patients are going to suffer from some type of expressive dysphagia, or they're not going to have clear speech, even if they are able to tell you what they want. And so if they do not have that clear speech, they're going to be scored at a 3, which is exhibits some difficulty with expressing needs and ideas, or speech is not clear. Otherwise, we have the frequent difficulty with expressing needs, or rarely or never expresses self, or speech is very difficult to understand. And then understanding verbal content. They understand with clear comprehension without cues or repetitions. They usually understand, or they're understanding most conversations, but misses some part or intent of the message, requires cues at times to understand. 2, they sometimes understand only basic conversations or simple direct phrases, frequently requires cues to understand, or 1, rarely, never understands. And this is going to be coded on their preferred language. So if we need an interpreter, we're basing this off of how well they're having a conversation with the interpreter too. And you can ask the interpreter whether or not they are speaking clearly or signing clearly, or if they're having a hard time understanding what the patient is trying to tell them. All right, so what do you have to do? For charting on rehab, it is BID, chart what you see. So once a shift, twice a day. So morning and night, you guys each have to do it once. And you're charting what you see. If you see them go to the toilet and you help them with that, we're going to chart on toileting hygiene and we're going to chart on toilet transfer. That being said, if another nurse helps your patient or if a tech helps your patient and you are able to ask enough questions to understand what kind of care or level of care was provided, you're able to chart on it. So let's say my CNA takes my patient to the bathroom and I say, okay, were they able to pull their pants down? And they say yes. I'd say, did you help them at all to pull their pants down? They said no. Were they able to wipe themselves? Yes. Did you provide any assistance in helping them wipe themselves? No. And then, were they able to pull their pants back up? Yes. Did you provide any assistance? And they'd say, yeah, I had to help them on their left side because they weren't steady and they weren't able to get their pants up on the left side, so I helped them get the left side of their pants up. I would say that's a partial moderate assist. We did less than half the effort, but we did still assist in that toileting hygiene. And so you guys are able to chart with an accurate source, a trusted source for what happened and who saw it. We're going to go over the QIM Weekly Team Conference. This is every Tuesday, only day shift. So this is only if you work days, only if you work a Tuesday. And then again, our admission and discharge. This takes the place of a regular admission and discharge. So those are going to be our forms. We're going to go over all those. So these are some screenshots. I encourage you guys to go into Cerner and open these forms yourselves so you can kind of scroll through them and get a feel for it. But this is our first page here. It's going to be different to start. We're going to have our preferred mode of communication. How did we get here? Did we get in a wheelchair or a stretcher? Our preferred languages. Any domestic concerns? Are we feeling unsafe or neglected at home? Do we have an established relationship with a health care agency? Do we have home health already? And then down here, should a brief interview for mental status be conducted? The answer is always going to be yes to start. We are always going to try. So when you hit yes, this box is going to pop up, and this will also be in your testing. This is a section you'll get tested on as well. So this is a cognitive test, a little bit of a brief interview for mental status. It has explanations for what you need to say, and we'll go through it here pretty quickly. So you're going to tell the resident, I'm going to say 3 words for you to remember. Please repeat the words after I've said all 3. The words are sock, blue, and bed. Now tell me those 3 words. And then you click the words that the patient repeats. You're going to click these boxes if they repeat them. And you're going to say, yes, the words were sock, blue, and bed. Sock, something to wear. Blue, a color. And bed, a piece of furniture. Sock, blue, bed. You may repeat the words up to 2 more times, and you're going to say how many times you repeated those words. What year is it right now? You're going to put in 2025 if the year is still 2025. And then the accuracy of their response. What month is it right now? I'm recording this in September. The accuracy of their response. What day of the week it is. It is a Tuesday. And then the accuracy of their response. We're going to ask the resident, let's go back to an earlier question. What were those 3 words that I asked you to repeat? So let's say the patient says sock, blue, and I don't remember the last one. So we'd say that yes, they got sock without a Q. Yes, they got blue without a Q. And then since they didn't get that last one, we're going to say the last one was a piece of furniture. And they're going to say, bed. And so you'll click that yes. After queuing, they were able to say bed. And so then you're going to say that no, we were not unable to complete the BIMS. And you could just exit out of this box once you're in it. If you have a patient who is giving you nonsensical answers, or they are not able to communicate in any way, if they are in some way too distracted to answer these questions, or if they can't follow along, that's when you would say that they are unable to complete the BIMS. You would hit yes, and if you hit yes, this little box on the side is going to light up instead. And it says, are they able to recall the current season, the location of their own room, staff names and faces, that they're in a hospital, or none of the above were recalled? So this is our second tab here. There's some more questions here. Has a lack of transportation kept you from getting to medical appointments, meeting, work, or from getting things needed for daily living? And there are some options there. The ability to hear with hearing aids or hearing appliance if normally used, and their ability to hear. Same thing for vision with glasses. And then this one, how often do you feel lonely or isolated from those around you? Never, rarely, sometimes, often, or always. And then check all of the following nutritional approaches that apply on admission. Did they come in with a tube feed? Did they already come in with a mechanically altered diet, or none of the above? And then did the patient have major surgery during the last 100 days prior to admission? You will also be tested on this in your question. I took my test and it asked if it counted if a patient had an endoscopic procedure. They did not qualify an endoscopic procedure as major surgery because they are only, it's not a full sedation. I saw somebody get a question about this with Novocaine. Somebody had gotten a dental, like a cavity filling. That does not count as major surgery. And then has the patient had 2 or more falls in the past year or any fall with injury in the past year? This is also part of your test, and there's a section in your book to help answer those questions as well. And then if you keep scrolling down, we're only on that second tab still. This is just scrolling down. We have this option right here. This is going to look different on your guys' Cerner. I've worked with Billings Clinic to change this a little bit. So now all of these boxes at the very bottom have a none of the above option. So this is check all of the following treatments, procedures, and programs that apply on admission. So do they already have oxygen therapy? Are they getting CPAP at home? This here will say IV treatments. Very specifically, this is only if they're getting IV medications. So don't put antibiotics if they're taking pills. This is only IV medications and treatments on admission. And then cancer treatments. And then this box won't be here. You'll just have a none of the above in each of these boxes. And then down here at the bottom, signs and symptoms of delirium. Is there evidence of acute change in mental status from the patient's baseline? Some of our patients are not going to have this. You know, some of our patients are a left hip injury or a motor vehicle accident or a spinal surgery. So they might not have a change of mental status, but this is more going to be so for our stroke patients, those who are having injuries to their brain, who are having a change in mental status. And this includes not only ANO times 4, you know, do they know where they are, what year it is, what's going on? It also includes, are they far more lethargic? Are they far more worked up? You know, are they irritable? Are they restless? That is also a change in their baseline. So do they have inattention, disorganized thinking, or altered level of consciousness? And then your options are that the behavior is not present, it's continuously present and does not fluctuate, or the behavior is present and fluctuate, comes and goes with severity. This again is part of your testing, and there are sections on it in your book, your resource book. In the real world, I understand that sometimes we're getting patients and we don't know their baseline. This is the first time we're seeing them. They don't come in with family. Do your best. Do your darndest. We can probably assume from hanging out with them for a couple hours whether or not they're having a change in their baseline or if this is new or different for them for their stroke. And worst case scenario, we can always call family and ask those questions too. All right, so all of these other ones are mostly the same. The next different tab that you'll have is functional. This is now required on your guys' Cerner. but this is the best functional status achieved by the patient within 30 days prior to the hospitalization. So this isn't, I was a track star in 1960. This was, how did you best move in the last 30 days? And so we can say independent, partial assistance, total assistance, or unknown. And then did we have a last fall date? And then are we using any mobility or assistive devices? Most of these in the middle are the same. That PHQ questionnaire. Our vaccine screenings. The COVID vaccine is not required anymore for our charting. It is required by the Centers of Medicare and Medicaid. So if you guys remember to click this box, that would be great. That's extra credit for you. And then this is our discharge form. A lot of the questions on the discharge form are gonna be the same as the admit form. So, has a lack of transportation kept you from getting to medical appointments? How often do you feel lonely or isolated from those around you? These new ones here, at the time of discharge to another provider, did your facility provide the patient's current reconciled medication list to the subsequent provider? The answer is yes. We always schedule a follow-up with their primary care provider, and once you hit one of these boxes, this will pop up for you. And we usually send that electronic health record for their primary care follow-up appointments. And then at the time of discharge, did your facility provide the patient's current reconciled medication list to the patient, family, and or caregiver? The answer is yes. If we are discharging our patient, we should be printing out discharge paperwork, and that is going to include a paper-based or verbal-based method, preferably both. Always the paper-based. And so then at the bottom here, nutritional assessment. This box is for all nutritional approaches that were received in the last 7 days. So somebody could have been on a mechanically altered diet or a tube feed and are no longer on those things. So you might have to do a little bit of digging for that answer. But this other one is check all of the nutritional approaches that are being received at just discharge. So what are they receiving right now? And then if you scroll down, check if the patient is taking any medications by these classifications, not how it is used in the following classes. So are they on antipsychotics, anticoagulants, antibiotics, opioids? You're going to click whichever ones they're taking. And then once you click any of these boxes, this one's going to pop up and it's going to say which medications selected have an indication. I hope that they're indicated if they're receiving it. So hopefully your boxes checked over here should match your boxes checked over here. And then again, this is the same thing that was on our admission form. Like I said, it's going to look a little bit different from you guys. This none of the above is going to be in each box, so you have to click something in each box. And then otherwise, the rest of the form is the same thing that you guys have. And then again, the signs and symptoms of delirium is also on the discharge form. That PHQ. And then the education for your discharge, which is the same as your regular discharge form. And then the types of medications that are taken. So this is our last section, our weekly team conference nursing. Like I said, this is only if you are working on a Tuesday on days. This does not take the place of your daily QIM charting. You still have to do that one. But this one is in addition to on Tuesdays. And these boxes are pretty self-explanatory, but we're going to go over them real quick here. And I should say for context, this form is opened up during our weekly team conferences, and it is charted on by multiple people. So when you fill this out, you're not going to go to ad hoc to open this. You're going to go to your form browser, and you're going to open this by modifying it and modify the form that everybody else has filled out too. So it's a collaborative thing. If you guys have any questions on this, just ask somebody else who is oriented to rehab. If it's not somewhere you usually go, ask your rehab nurse, ask your charge. Worst case scenario, ask Veronica. Somebody can help you with this who's there in the building if you have any questions. So their nutritional status, modified diet, what it is, average consumption per meal, abnormal lab values, behavioral issues, are they oriented? And again, this is a chart by exception. If they aren't having it, then don't chart it. What's their pain level? Where's their pain at? Are interventions for pain? Infection? Antibiotics that they're receiving? IV antibiotics? And then the end dates for those. Are bladder continence and bowel continence? And then I'm scrolling down here to see the rest of the form, which includes renal, dialysis, cardiac, circulatory, and peripheral. Are those all within normal limits, or do we have issues? Respiratory, neurological, and then skin. A lot of our patients are going to have skin issues. If you click impaired, this box will open up and you can say what kind of impaired skin they have. And then this box will open up and just put some basics in here. Let's say left craniotomy, closed, with staples, open to air, with betadine Q day, or sacral stage 1 pressure injury, foam dressing, change Q day, whatever it is, just the basics of what their injury and wound is. And then risk factors for stroke, and then education provided for stroke. And then you're just going to save this when you're done with it, and all of our other people will add to the form as needed. That is it, my friends. I appreciate you watching this video so we can do our QIM education. If you have any questions on the actual testing, let me know. If you have not received a key code yet, let me know. I think I've gotten everybody. I will put my name and number in this email that I send to you guys. If you are taking the test, a reminder, you have to complete it before the end of September. Once you open your test, you have 5 days to take it. You can always leave and go back later. It will save your progress for you. There's a little button in the bottom left when you're taking your test that says leave. You can leave the test and come back. Do not hit abort. That closes out your test. If you take your test and you pass, congratulations. If you take your test and you fail any of the sections, just shoot me an email. I'll get you a new key code to take the test again just for those sections. You do need a new key code, and it'll take just those sections for you, so you don't have to redo the whole thing. If you guys have any questions, let me know. Otherwise, I appreciate you watching this, and good luck on your test.